Ait sgwael siam nisjalaja siam quanstanat senasnat. Good day, friends and family. I am Candace Wilson. I am the Vice President of City Club. Welcome. Today is June 22nd, 2022. The mission of City Club is to inform, connect, and engage our community to strengthen the civic health of our region. We emphasize civil conversations and listening to others. We begin by acknowledging with humility the land where we are today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, shorelines, valleys, and mountains of the traditional homelands of the Coast Salish people. And it has been this way since time immemorial. As always, I'd like to thank all of the volunteers who make our programs possible. I'd also like to thank KMRE Radio board member Robert Clark, who is producing today's program, and BTV, who will be broadcasting it for their viewers. I'd also like to thank our sponsors for their support. They are Bruce and Claudia Descend, the Opportunity Council, Baron Smith Dort, Attorneys at Law, Lemmy Commercial Company, Dane Neal of the Malinow Group, Colshan CPAs, Pacific Continental Realty, Unity Care Northwest, Village Books, Western Washington University, Whatcom Community College, Whatcom Community Foundation. So next, City Club, the next City Club meeting summary, we will host Representative Deborah Lacaniff in July to tell us about the large number of missing and murdered Indigenous women and people. Representative Lacaniff's legislation is to address this tragedy. So we look forward to next month's program in July. Finally, I'd like to turn things over to Pat Britton, who will moderate today's program. Pat?
Thank you, Candace, and welcome to everybody. Even though we're a little late today. But we're here to learn today about a Medicare program that was initiated in 2021, which has largely flown under the radar of the national media and even members of our Congress. So if you haven't heard of Medicare direct contracting or Medicare REACH, which is its new name, you are not alone. Proponents of REACH say the program improves quality and lowers costs by bringing value to the Medicare healthcare delivery system. By contrast, there's a growing number of legislators and healthcare advocacy groups who predict that REACH will result in the end of Medicare as a public nonprofit insurance, social insurance program. It's a complicated issue. So we are lucky to have with us today someone uniquely qualified to help us learn about it. Dr. Anna Malinow, I think I got that right. I spent decades working as a pediatrician with immigrant, refugee, and underserved children in Ohio, Texas, Pennsylvania, and California. She is past president of Physicians for a National Health Program, co-founder of Healthcare for All Texas, and lead organizer for National Single Payer. She has authorized opinion pieces on how national single payer will improve patient care and bring us closer to social justice. She has been a speaker on healthcare reform and featured on national and international television and radio. She recently retired as a professor of pediatrics from the University of California in San Francisco. As Candace said, there will be time for questions after Dr. Malinow's presentation, and just enter it your question in the Q&A area. Don't use the chat feature as it's been disabled. Dr. Malinow, welcome to finally to Bellingham City Club. We're very pleased to have
you. Thank you so much. And yes, I apologize to everyone. I'm just going to go ahead and share my screen if you're all okay with that. Wonderful. Well, thank you, Pat, for that wonderful introduction. Jane and the Bellingham City Club for the invitation and the opportunity to speak with you today about DCE and REACH, threatening traditional Medicare. So for the next 30 minutes or so, what we're going to be doing is we're going to be talking about two separate but related programs called Medicare Direct Contracting Entities, also known as DCEs, as well as Accountable Care Organizations, Realizing Equity, Access, and Community Health, ACO REACH, which we will see as sort of the new name for DCE REACH. We're going to see how these programs threaten the agency and care of people on Medicare, of seniors on Medicare, as well as the solvency of Medicare. We're going to see how far we've come in opposing direct contracting entities and REACH, and what we still need to do in order to end this program. So when you think about Medicare, I like to think of it as a pie, but as you know, many of you know, it was passed in 1965, signed by President Johnson, to cover the healthcare needs, the medical needs of seniors 65 and over initially. And it always left a little space, however, for private health insurance because it contained the Part A, which covers 100% of your hospital costs, Part B, which covers only 80% of your outpatient costs, and then a Part D that eventually became a Part D to cover pharmaceutical, prescription drug costs, as well as a supplemental plan. So seniors were always on the hook for that 20% that the Part B premiums did not cover. And that 20% became the supplemental gap plans that beneficiaries had to purchase from private health insurance. So there was always a little space left in our public program for private plans. Now you can see this Medicare pie before 2003 that the vast majority of individuals chose this Part A, Part B, and the supplemental plan. Now, sometime around the 80s, the people at Medicare thought that seniors needed to have a choice of a private plan to manage the healthcare needs when they chose Medicare. And those became Medicare Plus Choice. And you can see that this pie, back from before 2003, a very, very small minority of beneficiaries chose that Medicare Plus Choice, right? To have Medicare, but to purchase a private plan. The vast majority of individuals continue to stay on traditional fee-for-service original Medicare. Now, fast forward to 2021, and you can see that a large chunk, there has been this ballooning of Medicare Advantage, which is the private part of our public program. So about 50% now of beneficiaries choose a private Medicare Advantage plan to take care of their Medicare, whereas about 50% of seniors still choose to stay on traditional, the Part A, the Part B, the supplemental plan, the Part D, the fee-for-service Medicare. Now, why is this important? Well, the reason it's important is because the total Medicare budget for 2021 was almost $1 trillion. Now, that's a lot of money. And you can see that private plans already are taking about half of that budget. Now, these private actors are looking at the other side of the pie and thinking, wow, we're still leaving $500 billion on the table. How can we get a piece of that? And so today, what we're going to be talking about is this piece of the pie, the traditional Medicare piece of the pie that is being threatened by DCEs and ACO REACH. Before we start talking about traditional Medicare, I would like to set up our conversation by talking a little bit about Medicare Advantage. Now, the private plans that have Medicare Advantage plans are making twice as much money from Medicare Advantage than from employer-sponsored health insurance. And you can see this chart, and we'll just walk through it very, very slowly. And you can see, take a look at the gold bars. The gold bars are the profits that these Medicare Advantage plans made in 2020 during the pandemic. And you can see that the gross margins per member per month for a member, an enrollee on Medicare Advantage was $188. And compare that to $80 in the group market. So these are workers that have employer-sponsored health insurance. Medicare Advantage makes twice as much from Medicare than they do from employer-sponsored health insurance. So the market for them is critically important that they keep Medicare Advantage and that they keep pushing and pushing and pushing that piece of the pie so that they get more and more and more of that, of those Medicare dollars. Now, under traditional Medicare, which is, the green piece of the pie. So let's shift from the red piece of the pie over to the green piece of the pie. Under traditional Medicare, Medicare pays the providers directly. What does that mean? That means that you, as a Medicare beneficiary, go to your doctor, then the doctor bills Medicare, and Medicare pays the doctor directly. It's very, very direct. However, under Medicare Advantage, Medicare pays the Medicare Advantage middlemen, such as United Healthcare and Humana, Anthem, Kaiser, and all the rest, to manage the care seniors. So the way that it works is Medicare pays these middlemen a capitated monthly lump sum for every beneficiary. And then they get to do what they want with that monthly lump sum, right? And we'll see what they end up doing, because the way that Medicare Advantage plans make money, and we're seeing that they're making a ton of money, a lot more money than they're getting from their employer-sponsored health insurance plans, is by three ways mostly. Most importantly is they're maximizing revenue from Medicare. What does that mean? That those monthly lump sums that they're getting, they want to make those lump sums as big as possible. And the way they're doing that is that they are choosing healthy seniors so that they know that they get this amount and then they're not going to need to spend it because the senior is healthy. And they avoid sick patients because that lump sum is not going to be enough to pay for that sick person's healthcare needs. And then the other thing they do is something called upcoding, which means that they make these healthy patients look as sick as possible on paper to Medicare so that they can get more and more and more money. But at the end of the day, they don't spend more money on that patient because that patient is healthy. So that's how they're maximizing revenue from Medicare. And they're minimizing the money spent on beneficiaries. And how do they do that? Well, they create narrow networks, they do prior authorizations, they deny care, they delay care, and that's how they minimize the amount of money coming in from going out. And finally, they amplify number 1 and 2 by increasing volume through enrollment. The incessant ads that seniors get October through December, trying to recruit more and more and more seniors onto their plans. Now, we know that Medicare Advantage plans cost more to the government, anywhere from $10 to $14 billion per year more for Medicare Advantage than for traditional Medicare, and they are not delivering better care. Now, when you look at traditional Medicare, 98 cents of every dollar for Medicare goes to pay for healthcare. Now, compare that to Medicare Advantage, where only 85 cents of every dollar goes to pay for healthcare, and 15% stays for administration and profit. So that's Medicare Advantage. So Medicare Advantage does save money, right? But not to the federal government. They're making money for themselves. And because they're being overpaid for each beneficiary, they can offer plans at a discount for beneficiaries, and particularly for beneficiaries who are on fixed incomes, that becomes very, very attractive, right? And they can offer extras like minimal amount of dental and vision. They do have out-of-pocket caps, unlike traditional Medicare, and they can offer things like home visits and gym memberships to try to recruit more and more and more patients. So it's a playbook that they're using. They're getting overpaid, they're recruiting more, they're paying a little tiny bit more, and then they just keep making more and more money. And that's how that graph that I showed you at the very beginning is working for them. Now, let's shift over to the green piece of the pie, which is the traditional Medicare, right? The Part A, the Part B, the D, the supplemental plan. Now, most people have not heard about direct contracting. Just as Pat said, it's been an under the radar program from the Center for Medicare and Medicaid Innovation. to lower costs and improve or at least not worsen care. Now, what does this mean? The CMMI, which is this innovation center, sits under CMS, which is the Center for Medicare and Medicaid Services, which sits under HHS, which is the Health and Human Services. So the CMMI was created by the Affordable Care Act in 2010 to come up with these payment models to lower costs and improve, at least not worsen care for seniors on traditional Medicare. Now, direct contracting entities were started under the Trump administration as a payment model that inserts a for-profit, for the most part, for-profit middleman called direct contracting entities to manage the care of seniors and people with disabilities on traditional Medicare. So remember how we had the Medicare Advantage sort of middleman there under people who chose Medicare Advantage? Well, now we have these under the radar DCEs that are getting those capitated fees from Medicare to manage the care of seniors and people with disabilities. Now, we went from traditional Medicare where the government paid the doctors and hospitals directly to Medicare Advantage where they paid the capitated fees, capitated amounts to a middleman. But under direct contracting, there is another set of hidden players, and those are the Wall Street investors who are absolutely flooding direct contracting middlemen with new money because they expect big profits. Now, this is a program under President Trump, right? So did President Biden, when he started, stop the DCEs? Well, sadly, no. You can see that DCEs started April 2021. There were 53 of them. And President Biden, instead of stopping this terrible program, expanded it. And now we have 99 direct contracting entities. And virtually any type of company, regardless of healthcare experience, can apply to be a direct contracting entity to manage the care of seniors and people with disabilities, including commercial insurers. All the Medicare Advantage plans are DCEs. Private equity firms, venture capital investors. And applicants are approved without any input from Congress because this Innovation Center has the authority to scale up any model that fulfills its criteria to all of Medicare without any oversight from Congress. Now, how do DCEs make money? Well, they use a very similar playbook. They maximize revenue from Medicare, just like Medicare Advantage. And they minimize the money spent on beneficiaries because DCEs, like Medicare Advantage, can keep as profit and overhead what they don't spend on medical services. So the money they're getting, if they're not spending it, they get to keep what they don't spend. And this really creates a very dangerous incentive to ration and restrict care for seniors and people with disabilities on traditional Medicare, threatening their care. And mind you, these financial incentives do not exist in traditional Medicare. Why? Because there is no middleman in traditional Medicare. Now, DCEs are threatening the solvency of Medicare. And how are they doing that? Well, let's go back to that pie, that Medicare, the traditional Medicare pie, where 98 cents of every dollar goes to healthcare and only 2% goes to administration. Compare that with a Medicare DCE pie, where they only need to spend 60 cents of every dollar on healthcare, keeping up to 40% for administration and profit. Now, grant you, it will be very difficult for a DCE to keep this much profit. It will be very, very difficult, but it's not illegal and it's not impossible. So most of them are not going to be making this kind of profit, maybe 25, maybe 30%, but still much, much more certainly than Medicare Advantage, than traditional Medicare or even Medicare Advantage. So the big question becomes, how do you enroll millions of seniors and people with disabilities into a direct contracting entity? Well, you don't tell them. Up to 30 million seniors and people with disabilities on traditional Medicare, remember, we're talking about that green piece of the pie, could be automatically assigned to or with a DCE without their knowledge or consent, threatening their agency. They rejected Medicare Advantage and they chose traditional Medicare, yet there's going to be this middleman managing their care, threatening their choice. And how is this happening? Well, it's happening through their primary care providers. Because remember that under Medicare Advantage, It's the plan that is recruiting really, really hard to get seniors to choose Medicare Advantage, right? Under direct contracting, they are not recruiting seniors. They're actually recruiting the physicians and the physician practices to join the DCE. And once that primary care provider joins the DCE, then all the panel, the patients in his or her panel are automatically joined to that DCE, the physician or the physician practice has aligned with. So this is happening without the senior's consent, obviously. And it's happening in two ways. One is through claims. So for example, this is not a bill. Many of you have received these. This is not a bill, it's a claim. So CMS is going through millions and millions and millions of claims for every beneficiary. And what they're trying to do is to identify the doctor. And if they identify that Jennifer Washington's doctor is Dr. Craig Seckelson, then what's going to happen is that if Dr. Seckelson has joined a DCE, then automatically Jennifer Washington gets aligned or assigned or enrolled into that DCE as well. And so that's how it's happening, very under the radar, very much without anyone's knowledge or consent. But the physician, although I will tell you that physicians don't have much agency either, and it's usually their leadership, their health hospital plan or hospital system that is making this decision for them. Now, true, every senior that is now sort of enrolled into a DCE is going to get an annual notice. They're going to get a letter like this. I've seen many of them. This is from Cascadia Community Care Alliance. They're going to be told that no action is needed, right? And they're going to be telling them that their doctor is now part of this DCE, participating in a program with Medicare. Your Medicare benefits have not changed. Your doctor asked, Cascadia Community Care Alliance to help see that you get the right care at the right time, and you still have the freedom of choice to go to any doctor, et cetera, et cetera. Now, if I get a letter like this and I see no action needed, honestly, I just toss it in the trash. One less thing for me to have to read. I think most people would do that. I mean, this really shouldn't count as informed consent. Now, the interesting thing is that when a patient is auto-assigned to their doctor's DCE, there is a way for them to opt out of a DCE, but they have to find another doctor. And that's how they can get out of the DCE. And you can imagine how difficult this is for seniors who have had a relationship maybe with their doctor for 20, 30 years, or all the other doctors belong to a DCE, or they are in a rural area where there aren't any other doctors, or even I live in San Francisco, and it's very hard to find a PCP in the middle of the Mecca here. So it's not so easy just to find another doctor. Now, DCEs do remain invisible to seniors, and I thank Pat and Jane for pointing this out to me, because seniors do remain in traditional Medicare. They still have their Part A, they have to pay their B premiums, they have to pay their supplemental plans. They can choose any Medicare provider, it is true, that accepts Medicare. They will not see any bills. But what changes radically are the financial incentives for their doctors. This is going to have a potential to erode the relationship and trust between the doctor and the patient. Because now the patient is going to be thinking, who is this doctor working for? Are they working for my best interest or the bottom line of the DCE? Now, let's make no mistake about it. The aim of the Innovation Center and of CMS is to have all Medicare fee-for-service beneficiaries, right, the green piece of the pie, and the vast majority of Medicaid beneficiaries into a care relationship like a DCE or like we're going to hear about REACH by 2030. So this is coming. So the big question is, well, won't Congress try to stop it? Well, sadly, until recently, most members of Congress had never heard of direct contracting. Most members of Congress, most doctors, most patients had never heard about direct contracting. And that was until November 30th, 2021, when a group of Physicians for National Health Program, you can see my photo there on the right, It was cold in DC in November. Went to Washington, DC, and we had a petition signed by over 10,000 individuals for Secretary Becerra, who's the Secretary of HHS. We went to deliver the signatures and we were denied entry. And as a result of that, we really started working with many hundreds of other healthcare activists, grassroots activists that called on their members of Congress, that wrote letters, that signed petitions, that wrote letters to the editor. We really got to work. And January 4th, 54 members of Congress sent a letter to HHS demanding an end to direct contracting entities. And on February 4th, Senator Warren held a Senate Finance Committee hearing where she called DCEs vultures. Now, as a result of this huge grassroots effort, pressure campaign, there was a counter frenzy of lobbying by panicked DCEs as they saw their stock tumble because they were really worried that we were making a difference, that CMS might possibly end the program. So the CMMI felt really pressured to make some kind of an announcement, which they did of all days, February 24th, because of the increased scrutiny. But sadly, as we will now find out, President Biden, rather than end a controversial Medicare initiative called DCE, what the president did is it gave it a makeover. And it changed the name from DCE to ACO REACH, which stands for Accountable Care Organization, Reaching Equity, Access, and Community Health. So we got to work. We said, okay, well, is this really better? So let's compare the two, right? So on the left, you have the column for direct contracting. On the right, you have the column for ACO REACH, the new name. Well, they both place third-party middlemen between seniors and the care they need. They both entice private equity and other Wall Street investors to participate. They both allow middlemen to keep up to 40% of the dollars they don't spend on care. They both automatically enroll seniors without their foreknowledge or consent. They both require seniors to change primary care doctors in order to leave the program, and they both have the potential to ensnare 30 million traditional Medicare beneficiaries. So when you do all the checklist, there's very little difference between them. As a matter of fact, this was really summed up by a Wall Street investment analyst who, the day after the CMMI announcement, wrote, the reforms of the ACO REACH are one part a public relations exercise and one part modest revisions that should tangibly impact the for-profit, that should not tangibly impact the for-profit entities currently participating in the model. And as a matter of fact, their stock started to trend upwards. The DCE stock started to trend upwards. The DCE, private equity, venture capital, and so forth, started to trend upwards the day after the announcement. So they are not worried that this is really going to be much different. Now, the rebranding did make a big deal of the new program's incentives to improve health equities, right? Who could be against health equity? But sadly, I believe that they're actually encouraging the REACH middlemen to profiteer in underserved communities. And how are they doing that? Well, they're going to be paying these REACH entities to simply report demographic data, which includes race and income. So if they report this data, then they get a $360 bonus per underserved beneficiary per year, regardless of how much the beneficiary care the beneficiary receives, right? So this is just easy money. Put in the race and income, and then boom, you get that bonus. You don't have to improve anything. You don't have to mitigate any of the inequities. And it does allow REACH to use these demographic factors to increase risk scores, because one of the things that they're saying that under REACH, they're going to be these guardrails where they're not going to be able to upcode as much as they were before. I'm not 100% sure. I mean, these guardrails don't start until 2024 anyway. But what's happening is that, sure, they might not be able to do these health risk scores, but now they're going to be allowed to use the demographic factors to increase risk scores, increasing their revenues, again, without providing any additional care. So as a result of our grassroots activism, in March, the Congressional Progressive Caucus issued a slate of executive actions for President Biden to take. There were 54 executive actions. Number 2 on the list was ending direct contracting entities. So, which President Biden could issue an executive action tomorrow and end direct contracting entities with a stroke of a pen. So there have been many nationwide actions against DCE REACH. I just mentioned the Congressional Progressive Caucus. The Arizona Medical Society passed a resolution against direct contracting REACH. The Arizona Democratic Party passed a resolution against DCE REACH. As you might or might not know, and it's fabulous that the Seattle City Council passed a resolution against DCE REACH. The Virginia 11th Congressional District Democratic Committee passed a resolution against DCE REACH, and there have been many retiree labor groups that have passed resolutions against DCE REACH. And the most active among them, and I encourage you to read about the work that they're doing and join what they're doing, the Puget Sound Advocates for Retirement Action, also known as PSARA. They're doing amazing work. You should go to their website and join what they're doing. There have been select state chapters from the Alliance of Retired Americans that have passed resolutions against DCE REACH. Those states are California, Ohio, Kentucky, and Minnesota. The Minnesota State Council of Machinist Retirees also passed a resolution against DCE REACH. And the Machinist Local 751, representing Boeing's workers in the Seattle area, passed a resolution against DCE REACH. So we really have accomplished a lot. But Wall Street is not going to give up. Remember, $500 billion are at stake. We need everyone who cares about seniors, who care about people with disabilities, who care about the future of Medicare, because remember, if we don't stop the privatization of Medicare now, there won't be any Medicare for all left to fight for. So how do you get involved? Well, you can call the White House, you can email the White House, you can sign a petition for President Biden, urging him to stop direct contracting entities, to issue an executive order, and he can do this tomorrow with a stroke of a pen. So there's a link to the petition that you can sign. You can also write letters to the editor, write articles in your local news outlet, and contact your member of Congress. Now, I know that Representative Larson just wrote a letter to Secretary Becerra urging him to stop direct contracting entities. That only happened because of the pressure that he got from his constituents. It's amazing, and it works. So we really want people to do more of that. So you have 2 senators, they need to hear about direct contracting entities as well. And you can have your own local actions, right? Because, for example, in California, we are organizing a local action at the federal office to celebrate Medicare's birthday, and we need people to demonstrate, to let people know, to let our elected officials know that this is a program that is threatening to radically transform Medicare as we know it. So in summary, we talked about the 2 separate, related, and very similar programs. We talked about DCEs that are going to end in December of 2022 to be replaced by accountable care organizations, realizing equity, access, and community health, also known as ACO REACH, as of January 2023. These DCE REACH threaten the agency of seniors by auto-enrolling them without their consent. It's threatening the care of seniors by handing the medical decision-making process to entities with financial incentives to restrict care. It's their bottom line that's at stake here. And they threaten the solvency of Medicare by allowing these entities to keep up to 40% of the Medicare dollars for profit and administration. Now, we've come a long ways. CMS ended DCEs, right? That was a very minor victory, but then turned right around and rebranded them into REACH. In fact, you know that there's very little difference between the 2 programs. I didn't mention this, but the 99 DCEs, the currently existing DCEs, will transition to become ACO REACH in January 2023 without needing to reapply. The CPC included ending DCEs as one of the executive actions. That's the Congressional Progressive Caucus. There have been local resolutions passed against DCE REACH, and what we still need to do, well, we need to end DCE REACH by urging President Biden to issue an executive action. With an executive action, he can end DCEs tomorrow with a stroke of a pen. We need to end DCE REACH by lobbying your member of Congress, lobbying your senator. Continue to do this all over Washington. You guys are really, really far ahead of the game, but really doing great work. And then we need to continue passing resolutions at the state, local, party, union, and professional society level. So I want to thank you for your time. It's been a pleasure and an honor. For those of you that would like to find out more, because I was told to speak slowly, but now I realize that I was probably talking a mile a minute, you can go to our website, protectmedicare.net, where you can find out a ton of information. You can also go to the pnhp.org website. You can follow National Single Payer, which is the new organization I'm working with, at NSP Healthcare on Twitter, on Instagram, and on Facebook. And there's my email that you can email me and ask me more questions. So thank you very, very much. I'll stop sharing. Great.
Thank you so much. I think I'm on now. Thank you so much for your presentation. I've studied this quite a bit, and I've learned so much more from just hearing you talk more about it. We have a couple of questions from the program board that I'd like to ask. Every industrialized country in the world has single payer or government mandated healthcare except the United States. They also spend less of their GDP on healthcare and have better outcomes than we have in the United States. With the advent of direct contracting and REACH, it appears that our Medicare system is moving kind of in the wrong direction and that towards privatization. Can you tell us just more of your thoughts on the matter?
You're absolutely right. When you compare the United States to peer countries, right, to the European countries, to Australia, Canada, we outspend almost every other country by twice as much except for Switzerland. We still outspend Switzerland, but not by twice as much, but every other country, we outspend them by twice as much. Yet our outcomes are not as good. We know that our life expectancy is lower. We know that our maternal mortality is higher. Our infant and neonatal mortality is higher. So for many, many, many metrics, we just don't do as well as other countries that spend half as much money as we do. So you have to wonder why it is that these payment models that CMS has been using literally since the 70s to lower costs and improve care have just not worked. And here we are in another iteration of these payment models, right? We have this new iteration. The DCE ACO REACH is the new iteration of managed care that has not improved outcomes, that has not lowered costs. And yet we still keep sort of beating the same dead horse instead of looking at real solutions, which would be a national single payer healthcare system that, you know, an improved and expanded Medicare for all, that would lower costs for sure. There have been many, many studies that have proven that. So if you really want to control costs, that's what you really need to do. And if you want to improve outcomes, I mean, not only do we need to have a national health system, which would have helped during the pandemic for sure. I don't know if you've all read the Lancet, the article, I believe, that was published in the Lancet just last week, that showed that 334,000 of our 1 million COVID deaths could have been avoided had we had a national health program. I mean, that's criminal. That is criminal. Yet we still keep thinking that these alternative payment models of the value-based care and the risk sharing and all those things, which are going to reward doctors for, you know, doing fewer procedures and punish them for doing more procedures. You know, this whole thing about fee for service and over treatment yes, over treatment is the reason for our elevated costs. That's just not the case. And we are going in the wrong direction. I 100% agree with you. The other thing is that you brought up the point about privatization of a public good. I think this is something we really, really, really need to look at very, very closely. What is privatization? Privatization is the transfer of a public good into private hands. There's this really excellent book that I don't know if you've all read called The Privatization of Everything by Donald Cohen and Alan Mikayon. And if you don't mind, I'm just going to read one sentence. Privatization is facilitates the upward transfer of wealth, exacerbates inequalities, creates powerful interests, separates us from each other, and segregates us by race and class. So that's the problem with privatization. And that's the direction that we're heading in. Now, the next sentence in this paragraph is that, and privatization is not too big for the average citizen to take on, because if you read the book, you'll see that there are many, many, many instances where local groups have taken on large privatization. And that's exactly what we're doing right now by raising awareness and by getting people involved in this anti-DCE campaign.
Thank you. And just one more question from me. For adults not eligible for Medicare, why should they care about REACH or DCEs or the direction of Medicare policy in general?
You know, that's an excellent question, Pat. And it's, maybe I didn't stress it enough, but thank you for asking that question because it does need to be stressed. Exactly. You know, say you're 30, what do you care about Medicare, right? I mean, it's so far away. But the truth is that, just as I said, if we do not protect Medicare now from these privatization corporations, these corporations that want to take it over, there won't be any Medicare for all left to fight for. And this latest iteration of managed care really is threatening to bankrupt Medicare. So if you're thinking, oh, I'm 30, I don't need to worry about it, for another 35 years, it'll be there for me. Well, it might not be.
Well, thank you. This has been really enlightening for us. I'm now going to turn the program over to Heather Erb, who's been accumulating what I'm sure is quite a few questions from our audience. And for my part, thank you so much for being here. Take it away, Heather.
Thank you, Dr. Malinow. We do have a lot of questions, and I'm going to apologize to everyone ahead of time. I'm not going to get to all of them, but we're going to try. I know this is a question that's on quite a few people's minds here in our area. First question, I recently received a notice via my Peace Health patient portal, Peace Health being probably the biggest provider here in Whatcom County, stating that I have been placed into a DCE. I did not get an opportunity to opt out in advance. At this point, do I have any options for getting removed from the DCE?
Well, first, let me say that you are not alone. That sample letter that I put up is just one of many that I've seen because seniors are now being placed into DCEs. I believe that something like 1.8 million are already in DCEs. Peace Health is a very large DCE in your area. And my guess is that your letter is very similar to the letter that I posted on my slide deck here, that you have been placed into a DCE. Well, what can you do about it? I know that there's probably a phone number at the bottom of your letter to call either Medicare or to call your provider. And I will tell you that the experience of people that I have known that have tried to call Medicare to get some kind of an explanation has been dismal. A lot of the times they're speaking with operators that have no idea what a DCE is. And even if you were to call your provider, oftentimes the providers don't know this themselves either. So I don't lay much stock in calling those phone numbers, unfortunately. The way that you can get out of this DCE, as I mentioned, is to leave your primary care provider. And then hope that your next provider hasn't already or will not be shortly aligned to a direct contracting entity. In fact, I know that this is the case because a group of physicians for National Health Program did have a meeting with Liz Fowler, who is the director of the CMMI, in December of 2021. And I asked her that question specifically. So this is the director of the program. And I said, well, so what if a beneficiary just wants to opt out of a DCE? What choice do they have? And she said, well, yes, they can opt out. They can, but they just have to change their doctor.
Okay, so I want to follow up on that because here, Peace Health is the major provider. I don't want to say they have a monopoly, but there are, for many folks, they may not have the option in certain communities to find another provider if it is one entity that is the main provider. Have you seen much success in communities going to a major provider such as Peace Health to advocate for no longer being part of the DCE?
I wish I could say yes, but these are financial decisions that the hospital system is taking. And unfortunately, it's hard to argue with their bottom line. It could very well be that there are physicians there that truly believe that this is the way to lower costs and improve care. I don't doubt it. Unfortunately, the evidence just isn't there for these managed care organizations and programs to do that. So unfortunately, I think that it's misplaced trust in that kind of a payment model. Yes, I mean, let me just say that in Louisville last year, we did have a protest in front of the Humana headquarters in Louisville, Kentucky. They do run a DCE, and we had a nice big demonstration in front of their office. I don't think that they really cared, honestly. I mean, I think it's good to have these protests to raise awareness. I think that that's really important. But whether we're going to be successful at shutting these down if we protest in front of their office, I mean, maybe, I don't know.
All right, thank you. Yes, okay, and we do have a few people raising their hands. I just want to let you know we're doing questions through the Q&A box, so please put your question in the Q&A box. All right, our next question is, many doctors will not accept Medicare payments. Do they get higher fees from the Medicare Advantage programs? If I got the same care I would do without an Advantage program, as the costs are significant.
So most hospitals, most providers accept Medicare. So I'm not sure that I agree with the premise. And what ends up happening with something like with a DCE is that providers are incentivized because they themselves might get a capitated fee for their beneficiaries, for their patients on their panel, and they might get capitated fees. And so their incentives then will be to try to lower costs for that beneficiary. And you can lower costs by keeping patients out of the hospital, it's true. But you can also lower costs by sending your patient to a cheaper cancer center, right, where they might not be getting the best care possible.
Okay, and I think you sort of answered this question already, but how does a Medicare subscriber know if a DCE is managing their care? So maybe you mentioned the letter earlier in your presentation, maybe they didn't get the letter, or they just put it in the recycling bin and missed it, or didn't even know, it didn't catch their attention.
Well, this is the big question. It's going to be invisible. It really will be. And the only thing they can do is the next time that they go see their doctor is to ask their doctor and say, are you part of a direct contracting entity? And wait to see what the doctor says. To be honest with you, I have had patients call the physician office and speak with the receptionist, and they They don't know. They don't know. I think that it's a question that you need to ask your physician.
Okay. We got a question. Where does AARP stand on these middlemen?
Good question. Where does the AARP stand on these middlemen? Well, the AARP sells their own Medicare Advantage plan. So you can see where they might have a little bit of a conflict of interest. So they think Medicare Advantage is great because they actually make a lot of money from those plans. And yep.
Okay. We have a question about the upcoding process and how it works, and wondering if you could explain that a little bit more.
Yes. Okay. So I didn't explain it during my presentation because it's a little bit too much policy, I think, for most people. But if you are willing to sit through this, I'll try to do this really as briefly and succinctly as possible. So say that you have a 75-year-old woman who has certain medical conditions, right? She has heart disease, she's got a little bit of COPD, and she has a little bit of high blood pressure, right? Now, every single Medicare beneficiary, every single one of them has a risk score attached to them. You don't know, if you're on Medicare, you don't know what your risk score is, but you have one. And the sicker you are, the higher the score, the healthier you are, the lower the score, okay? So you have this 76-year-old woman. So her baseline score, just because she's 76 and is a woman, is, let me just make up a number, 0.45, okay? I'm making up this number. That's her baseline risk score because of her age and because of her gender. Now, because she's got some high blood pressure, her risk score goes up a little bit. So, you know, that drives it up 0.33 more. Because she has some other heart disease, it drives up her risk score a little bit more, 0.5. Because she's got COPD, it drives it up a little bit more. So you end up adding her baseline and all of these other extra risk scores because of her illness, and that's the number that you get at the end of the day. And Medicare will pay that Medicare Advantage plan a certain amount for that patient with that risk score. Now, that's a Medicare Advantage plan that does not upcode, right? It's very, very careful, and you know, she only has this, and she gets this number. A Medicare Advantage plan that does upcode, instead of, I mean, she's got the baseline, the same 0.45 because she's still 76 and she's still, you know, her gender is female. But instead of saying that she's got hypertension, now you say that she's got something like malignant hypertension or hypertension with, you know, nephropathy or something like that. Then her risk score, instead of, you know, for that 0.33, suddenly goes up to 1.33. Then her heart disease that was, you know, simple plain old heart disease now is congestive heart failure with level 3 something or rather. Her risk score goes up to 2. And then her COPD, instead of calling it chronic obstructive pulmonary disease, you call it asthma with an exacerbation and all that. Then her risk score goes up to 1.2. Mind you, it's the exact same patient, the exact same 76-year-old woman, right? She's not any sicker. She doesn't require any more health services. But her risk score now is 3. If you add up all those numbers, her risk score is now 3. And Medicare will reimburse that Medicare Advantage plan that has upcoded, and this is all legal, okay? It's just cheating, but it's legal. They will reimburse that plan instead of the typical $9,000 that they would be reimbursing a plan that doesn't upcode. Now they will reimburse that for the exact same patient, $30,000 per year. So the difference is astronomical. And so there's a huge incentive. Obviously, if you're a corporation, if you're, you know, your social responsibility is to your business, right? Not to your patients. And so that's why there's a huge incentive, and this goes on and on. It's been documented. by the Office of Inspector General, by MedPAC, that this is exactly what Medicare Advantage companies do. And that's why when I showed you that graph, that their margin is $188 per member per month compared to the $86 per member per month, is because they're doing all that upcoding and making healthy patients look sick on paper. At the end of the day, she's not using any more healthcare, and they're going to be spending $9,000 on that patient, but they get to keep the balance of, the $30,000 minus the $9,000. So that's how they're making money, and that's what upcoding is, and that's what DCEs have been doing. They have been doing this for the past couple of years. There's documentation that they have been doing this. However, the REACH tries to put a cap on that so that they can only go up 3% per year using the traditional Medicare as the baseline. But these caps don't start until 2024. The program actually ends in 2026, so it gives them plenty of time and opportunity to upcode in the meantime. I don't know if I made myself clear, but it's cheating, honestly. That's what it is, but it's legal.
No, certainly when it comes to some of these questions, they're not 1 minute answers, given the complexity of our healthcare landscape. So no, you're doing great. So we have some questions more about the political landscape. And you did cover some of that in your slides, which, by the way, just a side note for folks asking about the slides and the presentation, they will be available on the website. But has President Biden made any statements publicly about DCE's REACH, and what advice might he be getting from our current Secretary, Xavier Becerra?
Great questions. So no public statement from the president. In fact, no public statement from Secretary Becerra either. He has, or his proxies have, written letters in response to our letters. He signs them, or sometimes his deputies sign them, but they're always standard form letters saying how they are putting up guardrails to make the program safer and more cost effective and cost efficient. So I think that the Democrats really have an amazing opportunity here if they wanted to end this terrible Trump program. I mean, they can just really lay the blame on the Republicans if they want to, because the direct contracting entity was a program that was launched in 2019 by the CMMI director, Adam Boehler, who was appointed by President Trump. And he got his buddies at Oxyon Venture Capital to help write this program, and which was launched in 2019. And so President Biden and the Democrats have this amazing opportunity to say, wow, look at us. We are going to be protecting seniors from these venture capitalists and from the private equities. We are, and from the rapacious Medicare Advantage companies. We are going to be protecting seniors, and this is how we're going to do it. We're going to end direct contracting. We're going to keep traditional Medicare public. I think it's an amazing political opportunity, especially during the midterms, something that they could do. But there would be a lot of backlash from the industry, and the industry, I'm sure, pays for a lot of their campaigns.
Okay. And again, we're getting requests to speak from the audience, and apologies, but we are accepting all of the comments and questions through the Q&A box, please. So and this is back to the upcoding, would a patient know that their health status has been upcoded by looking at their EOBs from CMS?
That's a good question. I don't know. I don't know the answer to that. I don't know.
Okay, fair enough. So in this, we're getting a lot of similar questions, and I apologize if you may have already answered this. So REACH scans will approve doctor requests for treatments rather than Medicare. So I am likely to get cheaper treatment options that are also less effective, is the question.
So how is this going to work exactly? Because you do have the choice to go to any provider. You're still under traditional Medicare, and so you have the choice to go to any provider, and it's portable, right? So if you want your cancer to be treated at, Dana-Farber or at MD Anderson with Medicare, with traditional Medicare, you can still do that, even if you're in a DCE. But let's see what's going to happen with these DCEs. In order for them to be able to save money, because that's really what they're doing, they're saving money and they're improving care, right? So in order for them to be able to save money, how are they going to do that? Well, they will create networks of specialists. They will be signing contracts with specialists, with hospitals, with cancer centers, and they are going to tell their providers that they want their patients to be seen within these networks. Now, this is what Medicare Advantage does all the time. And people on traditional, on Medicare Advantage have no choice. They have to be within their network. Now, under traditional Medicare, they would have a choice, except you go to your doctor and you've got this lump and everybody's really worried, and your doctor says, okay, well, I think, you should go to Cancer Center, B- over here. And you're thinking, wow, I think that Cancer Center A+ across the street is really, really much, much better, but my doctor is telling me to go somewhere else, and I really do trust this doctor, or maybe I what's going on. And so I think that that's what's going to end up happening, that the reason why there's going to be a huge incentive for these DCEs to pressure their physicians to keep patients within the network is because Medicare is giving them this money for that patient, right? And every single time the patient gets a service outside of the DCE network, then that other doctor bills Medicare, and Medicare pays that doctor, right? And at the end of the month or at the end of the year, Medicare is going to reconcile all those extra payments with the DCE, because the DCE is responsible for that patient now.
Thank you. Next question is about employees and their relationship with their employers, who might, according to this person, their employer is getting a hard sell for a DCE called Alliant that is promising a savings to them of about $2 million plus a year. And the person is concerned that this is a bait and switch, because the savings are only guaranteed through 2023. And then after that, they may be free to raise the rates. So what can employees and retirees do about this?
That's a new one on me. I hadn't heard, but of course it makes sense that DCEs would start trying to do this. Medicare Advantage plans have been doing this for a long time. So what can employees do and retirees do? Well, you might have heard of what's happening in New York City, where the municipal employees who were promised during their retirement that they would be able to retain their traditional Medicare with a supplemental plan were switched by their union without the knowledge of the workers to a Medicare Advantage, because it saved money to the union, as well as to, because they were municipal workers, to the municipal government. And those workers took I believe it was, they took the city to court, and they won one, but not the other. So I'm not exactly sure the state of that lawsuit right now. But that's something that other retiree groups are doing. They are organizing and either filing lawsuits or trying to pressure their employers not to make the change. But the problem is that healthcare in this country is so expensive, and particularly for employees and employers. And if you look at the graph of the amount, since 1999, health premiums have gone up 224% since 1999. And the workers' contribution to those premiums have gone up 270%. So obviously, if there's an employer that's looking at, plan A that's going to save me $2 billion a year, wow, I'm going to go with that. Even if, after 2023 or 2024, who knows what's going to happen, because the employer doesn't know what's going to happen in the other market either. So the real way to fight this is to fight for a national single payer bill where employers wouldn't have to do this anymore, and neither would retirees or union employees or anyone. It would just be part of the national fabric. Everyone would be covered. Everyone would have comprehensive, affordable, accessible healthcare. That's what we need to be fighting for.
Okay. And you mentioned what some governments are doing, including the Seattle City Council. What can states do in response?
Well, we've been working with Democratic clubs to put pressure on their representatives, to pressure President Biden or pressure Secretary Becerra to stop this program. You could work with the Republicans as well. This is something that affects everyone, right? It's really not bipartisan. It's an everybody issue because Republicans become seniors as well. So it's threatening them also. But so those are some of the things that we're doing. As far as the states, I was thinking it would be really interesting for the Seattle City Council to pass a resolution, not only to write a letter to Becerra opposing DCEs, but it would be interesting if they passed a resolution saying that DCEs could not function in their jurisdiction. I'm sure they would be taken to court in like a heartbeat. But I think that would really make a difference. That would really make a huge difference, because then you would take away that possibility for these DCEs to start infiltrating more and more states.
Okay. Another question we have is about the American Medical Association and their opposition to HR 676. Can you speak to that at all?
Well, unfortunately, the American Medical Association, not that I'm a member, I have never in my 30 plus years as a pediatrician, I've never been. Am I still on?
Yep.
Yes. Okay. All right, good. The AMA has been a staunch opponent of single payer, unfortunately. And they were a staunch opponent of Medicare when it passed in 1965. I think that they're softening up somewhat in their opposition. They haven't said anything about DCEs except for the Arizona Medical Society did pass a resolution against it. But as far as the AMA, we've been reaching out to the California Medical Association. We've reached out to the Hawaii Medical Association. And unfortunately, there are just a lot of vested interests there. And but that doesn't mean that we can't keep pushing and pressuring them.
All right, thank you. Well, we've gotten, as I said, we keep getting requests for the slides and the presentation, and we can't say it enough. It will be on the website. I know that there were a lot of links that were provided in your presentation, so you'll be able to view those links when the presentation is posted. And Dr. Malinow, thank you so much for bringing some clarity to a very complex subject matter. And given all of the questions, the volume of questions that we received today, clearly this was a much needed discussion in our community. I'm sure communities throughout our country. So thank you very much for coming to Bellingham City Club. We hope you come back. And I'm sure this is an ever-changing landscape that you'll, need to update us on. So thank you very much for your presentation today.
Absolutely. Thank you for the invitation, for the opportunity, for the fantastic questions that you all raised. And absolutely, you will have access to my PowerPoint presentation and all the links. Please go to our links to sign the petition to President Biden and inform yourself some more. But thank you so much for the opportunity.
Thank you. And one important last announcement, some of you may have missed Candace Wilson announcing our next program, which you do not want to miss. It's on July 27th. It is on Seeking Justice for Missing and Murdered Indigenous Women, presented by Representative Deborah Lekanoff. And some of you may not be aware, but Washington State became the first state in our nation to pass legislation this year to address this crisis by creating a statewide alert system for missing and murdered Indigenous women and people. So you don't want to miss that. She's the one who spearheaded the legislation, so she'll be able to give us an important update on implementation and also what's going on at the national and state levels. So thank you also to our moderator, Pat Britton, for doing a great job. Thank you to you all for your amazing questions and being so engaged. And we look forward to seeing you at the next Bellingham City Club program. Thank you.